Hi, Dr. Collins.
Hey, Daryl, how's it going?
Very well. I hope it's going well for you too. Challenging times still, and we'll get through them, I hope. Can you tell our audience what you do and where you do it?
I actually have the best job in the world. First of all, I love living in Washington, D.C. I'm a radiation oncologist at MedStar Georgetown University Hospital. I've been doing it for 15 years. I get to take care of older men every day, and I do a lot of quality of life research, and I just love my job.
That's super. And are people coming to you because they're older men or because they have prostate cancer and happen to be older men?
Well, I take care of all men with prostate cancer, but most prostate cancer patients, I would say the typical range for prostate cancer is like I usually see 50 to 80-year-olds.
Mhm.
But most of the men who get treated with radiation in the United States are probably more like on the 70-year-old side. And we treat less men that are most men in the United States that are 50 and younger are probably getting surgery.
Okay. And you said 80-year-olds. There are probably people who are doing active surveillance in our audience that are like clenching their teeth. Uh, you know,
Well,
uh,
the thing is that there are like 80-year-olds. By the way, my experience is that 80-year-olds are a lot healthier today than they were 20 years ago.
mhm.
And if you have 10 years of life expectancy and you have a very high risk prostate cancer, you probably shouldn't ignore it.
Yeah. Yeah, and 80 to 90 gives you that 10-year window of enjoyable life as well.
Yes.
Yeah. So today we're doing Pride in Prostate Cancer. It's a conference focused on men who enjoy sex with other men as well as transgender women. Can you talk about like what you've know? I mean, to the extent that you know who your patients are who are gay or enjoying sex with other men, what might be the difference in terms of like the first meeting, like when they sit down in your office? What are they asking? What are gay men asking that straight men aren't, and vice versa?
It's funny. One of the things that I always do when I meet patients is I have a quality of life questionnaire that they fill out before they see me. And I actually, there's many aspects of prostate cancer and its impact treatment, its impact on quality of life. So we give out extensive questionnaires about sexual function. We have a questionnaire about ejaculation. I try to provide a very open environment for any question that someone wants to ask. The environment that we're in, especially being in Washington, D.C., which I think is a relatively open environment, I feel comfortable answering most questions, and usually it's a back and forth between us.
Right. And do you think the same is true for your staff? That like your nursing and receptionists are present a comfortable feeling for your patients showing up.
Oh, yeah, well, I mean, I really think that my staff, we're a team. First of all, radiation oncology is a team sport. It's not just one person doing the job. I am very blessed that I've had the same nurses, the same administrative assistants and helpers for the last 15 years, and I think we are very open. We're mostly Washington D.C. people, and I think our environment is great.
That's great. So you're very cognizant of quality of life relative to the treatment you offer and how it relates to the outcomes patients experience. Let's talk about that. And let's talk about that from the perspective of people who are anal receptive, anal insertive, people who enjoy their prostates being massaged. What are, in general, what might be the reasons that radiation therapy might disrupt the pleasure of the prostate?
So this is your prostate, and your bladder is right here, your rectum is right here, and your penis is right here. So I mean, they are very close together. It's almost impossible to radiate a prostate without getting some dose to the rectal wall. The good news is modern radiation techniques actually give a relatively low dose to the anal canal. but the anterior rectal wall, which is right next to the prostate, can get a significant dose of radiation. So, it's your prostate does not, if you have surgery, your prostate is removed. If you have radiation, you still have a prostate, it gets smaller. It does feel more rubbery when I examine it, when people come for follow ups, but at least you still have a prostate. I'm going to be honest with you. I haven't had a lot of patients report to me that they have loss of sensation in their prostate after radiation, modern radiation treatments. And I haven't had a lot of men report to me that being anal receptive is more painful after modern radiation techniques. One of the problems I have is that I'm Irish Catholic, if you can't tell. I think I'm a pretty straight appearing male, and I'm not actually sure that they confide in me that information. Maybe I should be asking more. What do you think?
Oh, sure, ask away. Um, there's nothing a shy man or a fearful man likes better than to be asked something that basically makes that fear evaporate.
Right.
And when a doctor asks, do you enjoy your partner's finger in your butt, or penis, or
Yeah.
what kind of sex do you enjoy? Because our therapy may change that for you.
Right.
I mean, that dissolves like light years worth of anxiety. In male care, uh so we have like 84,000 people we're taking care of now in our support group network, but 50,000 of them say that the main reason they of this last year and a half of this COVID period who are online, over 50,000 of them say, out of the 84,000, say they came to male care to reduce anxiety.
Okay.
And they say that in different ways, but basically it's about getting a good night's sleep. It's about holding a glass of water without your hand shaking. you know it's just about having conversations with people and remembering the words you said 3 seconds before they came out of your mouth, or something like that. I
Mhm.
mean, it's everything about cancer is scary.
Yes.
That's almost a trope that, it's not even worth repeating anymore. But imagine being a man who has already been challenged every day of his life to be out, and he doesn't know the consequence of being out as a gay man or bisexual man to the person opposite him,
Mm.
whether it's the checkout counter or the radiation oncologist who really holds his life in their hands. Um, Tell us about modern radiation therapy.
Yes.
You use that phrase. What does that mean?
So I'm going to ask you some questions today that I actually don't know the answers to.
Oh,
So
cool.
when we do radiation to your prostate actually moves. So we generally put, I do a lot of SBRT, or stereotactic body radiation therapy, which is just very highly accurate radiation in a few treatments. So I put gold markers in the prostate so that we can track your prostate, and so I usually will put them through your perineum, which is the skin between your scrotum and your anus. It's 3 needle pokes. It takes me 15 minutes to do it. I usually do it under anesthesia because I don't like seeing men in pain. And those gold markers are placed in the prostate so that our cyberknife can actually track the gold markers and treat with sub-millimeter accuracy. When you treat with sub-millimeter accuracy, you only end up treating a very small amount of the surrounding rectum, bladder, and penis. So with modern radiation technology, very little bit of the penile bulb gets radiation and a lot less rectum gets radiation. The problem is that your prostate is getting irradiated, okay? And one of the curiosities I always have is, so when you have anal intercourse, do you actually sense it in your prostate?
So most men would say yes, which is
Most men
why
would
they're
say
doing
yes.
it. Yeah. And I think many men would suggest that while it may be geographically centered around the prostate, it's this warm, fuzzy, delicious glow and ultimately climax with a massive orgasm, if they're lucky enough to get that, So, i- i- I mean, it's very comparable to how women describe their orgasms.
Yeah,
Do they like having a penis in their body? And, it also rhymes with some of the difficulties that women have. Do you really want a massive penis in your body, or do you want something manageable? And most women will say, the myth of the massive penis is really toxic. That's not what we're after.
right.
Same thing for many anal receptive men, as well as fingers and many fingers and fists for some
Mhm.
people.
So the my question for you is, do you think, from your experience of talking to men, do you think that it's just acutely that the sensation is damaged, or do you think it's damaged for the rest of their lives?
So that's a good question. And usually a couple of years after therapy, you get a sense it's the rest of their lives. Even though I don't see people, and I don't think any of our support groups have people who have attended for more than 5 or 6 years. But you would think that if something has been damaged over a 24-month period, and you would know this better than me, actually,
Yep.
the opportunity for repair has gone out the window.
Yeah. There's a new product out there where they put a gel between the prostate and the rectum, which decreases toxicity to the anterior rectal wall. But it does put a centimeter of gel between the prostate and the rectum. Um, do you think that would improve outcomes in terms of the sensitivity of the prostate, or do you think because you're treating the prostate with high doses, it wouldn't matter?
So let's remind myself and others that I'm trained as a social worker,
Yes,
and not once have I turned a linear accelerator on.
that's true.
Right. I've walked in many vaults, but never pushed any switches. So really, I mean, I don't know. I mean, I remember being at the hydrogel people's tabletop exhibit on the day they got FDA approval, and the three or four people, including I forget this doctor's name, woman from Turkey who was one of the scientists involved, were thrilled, ecstatic, and then grabbed me aside and started selling me on the thing.
Yes.
Uh, but then I started speaking to other people like you, other radiation oncologists, and it was a mixed bag as to whether they were going to use it or not. And I think that continues to this day. My question to you is, if it's such a clear-cut benefit, why isn't everybody using it? And if it's not, why is anyone using it?
So the thing is that I think if you're going to be a doctor who uses the gel, the placement of the gel has to be done in a very careful manner. So placing gold markers into a prostate is very easy. I think accurately placing a gel between the prostate and the rectal wall, and having it symmetrically 1 centimeter thick from the apex of the prostate to the base of the prostate needs to be done very carefully. And you got to make sure you don't inject it into the rectal wall. So I've probably placed about 300 so far, and but I've gotten excellent training. Like when I first started doing it, uh, the people from the company that make it were there with me for every case until they felt I was completely competent. And I'm thankfully I can say that I've never injured anybody placing the gel between the prostate and the rectum, because that would be a catastrophe if I injured someone with a procedure that is actually supposed to be protecting them. Okay, I think it's very useful at preventing late rectal bleeding. If you have a person who's like on blood thinners, or if you have someone who has ulcerative colitis or Crohn's disease, if someone has uncontrolled HIV that's not being appropriately managed with medications, they might be more prone to having rectal toxicity from radiation. or someone who's had previous radiation and you want to protect their rectum, I think it's really valuable. For someone who's getting standard treatment with a very accurate radiation device like the CyberKnife, I think it's less valuable. We also have a proton machine at Georgetown. Every person who's getting treated with protons needs a spacer because you want to have a gap between their prostate and their rectum because you don't want the air from the rectum interfering with the radiation beam. So it really depends on which treatment modality you're using and how it affects your wanting to use the spacer or not. Probably the most common place that I'm using the spacer now is for dose escalation. So what we used to do is just treat the low and intermediate risk prostate cancer patients with the CyberKnife or SBRT. But now we're starting to use it with more high risk patients. And it actually, what we're finding is that it requires a higher dose of radiation to cure men with high risk prostate cancer. And having a centimeter of gel between the prostate and the rectum really allows us to dose escalate to the prostate without damaging the rectum.
And when you say dose escalating, in my mind, and I imagine in the mind of the 1,000 or so people watching virtually and many more who will watch this on YouTube, you're just building more rads, more
Yes, I like
rays
that. More
into a
rad.
more rads into a well-defined place.
Yes.
Why would that be more? If you can define that place where you're pushing more rads, why would there be? I think why would there be more damage? I mean, is there spillover of these rads? The more you put in, they sort of leak out and mess up your
There is
rectum and other
always
things.
spillover.
Okay.
So if you want to get a certain dose to a certain area, radiation there's always a dose fall off. So the higher dose you give to the tumor, you'll always get a higher dose to the adjacent rectum. So this is just a limitation of radiation modalities. We know that usually right now we're doing a lot of MRIs on people with prostate cancer, and what we're finding is a lot of men with prostate cancer have, they have small deposits throughout their prostate, but they usually have a dominant area that has the most amount of cancer, and that's where most radiation failures are happening. So we want to give a very high dose to that area where we know has the highest chance of recurrence. Unfortunately, it's commonly right next to the rectum because the peripheral zone, which has most of the prostate cancers, is right next to the rectum.
So when you say right next, I mean you're literally mean like that.
It's
Yeah.
like this.
So is this a question of you just can't get the beam thin enough to differentiate between
The dose
prostate and rectum?
fall off. You can't get the dose fall off would be like the physics term for it. The dose
And
fall is going to be the limiting factor. You can't have 100% dose here and no dose here.
and people are going to ask, why is that? So let me ask, why
Yeah.
is that?
Things that we have. So the thing that I like about SBRT is that the accuracy is sub-millimeter, and its accuracy, like when you use photons versus protons, it's pretty forgiving about whether you're going through, fat, muscle, or stool. So nice thing about protons is that it has a very rapid dose fall off. The problem with protons is the machines are very big and it's hard to get sub-millimeter accuracy when you have a very large machine. Okay. So we are trying with sophisticated radiation to make our treatments more accurate. But every type of radiation has some problems. And the main problem from my experience with protons is it does have great dose fall off, but unfortunately it can't track prostate motion and it can't give sub-millimeter accuracy.
There are machines now that combine an MRI the cyberknife. And by the way, cyberknife isn't just a horse in the Kentucky Derby. It's
Yes.
an actual, it's a trademark name, I guess, or however, by a company, Accuray or something,
Yeah.
to sell their machine. Um, it's perhaps the coolest name, in the prostate cancer world. Uh, but as you describe, it's not a knife.
Yeah.
You know, is there any advantage to combining this stereotactic therapy with an MRI that's also guiding the machine in real time?
The thing is that um, I'm going to be honest. I do not have an MR Linux, and I've never seen an MR Linux work. I'm excited about having MRI guided radiation. Um, I'm just a little bit concerned that it might not have truly sub-millimeter accuracy. You can advertise something, um, but it's a difference between advertising and actually, it working in real world. I'm actually blessed that I have lots of friends in the radiation oncology community. And one of these days, I'm going to have to stop by UCLA, which has an MR Linux, or Cornell, which has an MR Linux, and sit and watch their procedure to see whether I actually believe that it has sub-millimeter accuracy and whether it can be adaptive. So one of the potential advantages of an MR Linux is that usually when we treat people with prostate cancer, we just take one snapshot in time where we do a treatment planning MRI and a treatment planning CT scan, and we assume that 2 weeks later the bladder, the rectum, and the prostate are going to be in the same position that they were the day we did the scans. One of the potential advantages of an MR Linux is that if the prostate, the bladder, and the rectum look slightly different 2 weeks after you do the treatment planning scan, you can actually maybe on the fly adapt the treatments to make them more specific for what the anatomy is at that given time that you're treating the patient. So I'm hopeful in the future that MR Linux will have sub-millimeter accuracy and will be able to adopt to the actual anatomy at the moment that you're treating, like what the bladder, the rectum, and the penis look at the moment you're treating them. Because I think that would be the ideal treatment if it's feasible in the future.
So we've talked about the technology and this hydrogel thing. Basically, the main points of conversation that patients need to get up to speed on when meeting with a radiation oncologist. Let's talk about quality of life, which is really what people are here for.
Yes.
So let's start with this. Like, is there any reason for a man to choose surgery over radiation?
So very commonly, young men are directed towards surgery because um, we know radiation works well for about 10 years or 15 years. We have no idea how the new radiation modalities work 30 years down the road. Okay. So if you're a 50-year-old guy who's planning on living to 87, that means we have to control your cancer for 37 years. If you remove your prostate by the way, you have to have a very experienced surgeon do it who does lots of cases. And they get all the cancer, and when they look at the pathologist looks at it, there's no cancer cells outside the prostate. That is the best way to cure prostate cancer. Unfortunately, removing your prostate can have pretty significant quality of life impact. Some men have mild stress incontinence for the rest of their lives after they have their prostate removed. And people will say, "Oh, that's not a big deal. You wear a pad." I think it's a pretty big deal. Specifically, if you're still sexually active and you leak urine when you orgasm, I would argue that that's a big deal. Okay. Also, when you do the surgery, you have to spare the two nerves behind the prostate that control your erections. And by the way, there's vast variety of how good of individual surgeon is at doing that procedure. So if you have a really good surgeon, you might lose your erections for 6 months, but they'll probably come back like a year after the procedure. But unfortunately, if you have an inexperienced surgeon who's not good at sparing the nerves, you'll never have a normal erection again. So to me, that's very frightening to men. We tell them that, oh, don't worry about it. You can inject your penis with a needle and that can give you an erection. But that's pretty frightening for a lot of men too, that they might need to inject themselves to have erections in the future.
So, for a gay man looking to preserve as much erectile functioning, as much urinary continence, and as much opportunity to experience uh, pleasure from the prostate, which remains after radiation, to what extent is radiation screwing with all of the quality of life aspects that men want to preserve?
So when we radiate prostates, there's acute side effects and late side effects. Your prostate swells and your anterior anal wall swells when you get the radiation. So I would say that you probably have burning on orgasm when you're in the process of getting radiated and your prostate swells. You probably have burning on orgasm for about a month. I would say that anal receptive sex is probably painful for a month after the radiation, because your anterior rectal wall is swollen, your prostate is swollen. But I'd say most of that recovers by like 2 to 3 months after the radiation procedure, especially when you're doing very accurate radiation like robotic SBRT is with the CyberKnife. Um, Over time afterwards, what we've done is recently we've published a manuscript on ejaculation after radiation. And what we found is that ejaculation declines by 6 months after radiation. But we were pretty happy that most men after radiation could still ejaculate. Okay, so if you look 2 years after radiation, 15% of men couldn't ejaculate, but that also means 85% could. And they don't have zero ejaculate, they have a little bit of ejaculate. As we age, as men age, their ejaculate volume declines anyway. So it's, a lot of men who are in like their 60s or 70s are already noticing a decrease in ejaculate. With radiation, that declines, but it's usually not zero. In terms of erections, if you have erections before the treatment, most men maintain them for about 2 years after. The ones that don't maintain them or start losing them, usually Viagra, Cialis, or Levitra are highly effective as long as they have an adequate libido. So if your libido is good, if you've received radiation to your prostate and you are 2 to 5 years after radiation and your libido is good, and I prescribe you Viagra, Cialis, or Levitra, it has about an 80 or 90% chance of working.
Well, that's kind of astounding to hear. That's pretty good. But let's get into the weeds a bit. And when you say like pain upon orgasm, you mean an orgasm of penis sort of coming to
Yeah.
climax,
Yes,
right? Okay. So, because orgasm is also
I
experienced as
agree.
from anal receptive. Wh- what is radiation actually doing to the prostate? Make a picture for me.
Okay, I'll make a picture. So when we radiate a prostate, acutely it swells, inflammatory cells come in, your prostate gets larger, and that lasts for about a month. Radiation damages the DNA in the cancer cells, but prostate cancer cells don't divide that often. So they divide about every year or so. So what you notice about a year after the radiation, inflammatory cells start coming into the prostate, eating the dead cancer cells, remodeling the prostate, and the prostate starts shrinking. So by 3 years after radiation, your prostate is significantly smaller than it was when you were irradiated. It has less glandular tissue, so it produces less ejaculate. It actually feels like a rubber ball. It's interesting. It's actually softer than it was when you treated it. And it almost feels like your nose. When you examine a prostate 3 years after radiation, it feels like a nose. So you still have a prostate. It's rubbery. It doesn't produce ejaculate, but it's still present.
And the nerve bundles alongside.
It's the hypothesis is that because when you're doing very accurate radiation, the penile bulb gets a very low dose of radiation. The hypothesis is that the nerve bundles that control erections and probably also control orgasm do get fibrosis, which is wound repair over time. And that's why the penis doesn't function as well, and probably why some men would say that they have less sensitivity during anal intercourse.
And also the fibrosis impacts erectile functioning. Is that
Right.
correct?
Erectile function is because the nerves that control your erections are right behind your prostate, in between the area between your prostate and your rectum.
Right. And what about blood flow to the penis?
So the blood flow to the penis, the thing is that with modern radiation oncology techniques, the penis does not get a lot of dose of radiation. So I don't think it's a blood flow to the penis issue. I think it's a nerve problem.
Okay. Because in fact, I mean, Malecare is like a 23-year-old organization. It's, I mean, like early days, it was, radiation therapy will impact blood flow, and that's why you're going to have
Yes.
delayed erectile functioning,
When we look
disruption.
at the doses that our modern radiation give to the penis, it's very low.
Yeah. The idea that well, what happens to the rectum and the rectal wall?
Okay, so
And what do
these
you
things,
mean, actually, what do you mean by rectal wall? I mean, I
yeah.
just know what comes out of my butt, I mean, where's the wall?
So the rectum is a circular object, okay, and there's a wall around it. The stool goes through the middle of the rectum, and the rectal wall is right up against your prostate, okay. So that wall does get a little bit of radiation, and that rectal wall can fibrose. Now, when something fibroses, it becomes less elastic. So it's not as malleable. So one of the potential benefits of having the spacer in place, a well-placed spacer, is that that anterior rectal wall does not have as much fibrosis, is more malleable, and when the gel disappears 3 to 6 months after you place it, you'll have a smaller prostate, but your rectal wall will still hopefully be malleable and sensitive.
So smaller prostate is the goal of radiation?
Well, it's a consequence of radiation. I wouldn't say it's the goal of radiation. It's not a treatment for benign prostatic hyperplasia, but one of the benefits of having a smaller prostate 3 years after radiation is that most guys do urinate better than baseline 3 years after treatment.
Okay. So there are other ways to shrink your prostate,
Yes,
biochemical, using what's commonly called hormone therapy,
yes.
androgen deprivation therapy. So, a common question throughout all of our support groups for years and years and years is why mess with surgery or radiation? Why not just go straight to androgen deprivation therapy?
So androgen deprivation therapy has a lot of side effects. Okay, so by the way, I'm 53 years old and I'm already starting to feel frail. Okay, so androgen deprivation therapy is a pro frailty drug. You have hot flashes, you lose interest in sex, you gain weight, it weakens your muscles, it weakens your bones, it can make you feel fatigued, and you can feel depressed from it. So it is not a benign drug. It's also not a cure for prostate cancer. So hormonal therapy puts the cancer in remission, but if you don't do radiation or surgery, you cannot cure the prostate cancer. So one of the things that's been most exciting to me this year is we have new hormonal agents that I think are much better for men. What we used to do is give things like Lupron or Eligard, where you get hormonal injections either in your buttocks or in your abdomen. And these are generally 3-month shots that lower your testosterone. You would hope for 3 months, but actually, unfortunately, They usually your testosterone recovers very slowly, and my patients find it very upsetting not knowing when their testosterone is going to recover. They lose muscle mass. They feel like they are fatigued. They are tired. There's a new pill out there called Orgovix that I think is going to replace these hormone injections. And the main reason why I think it's going to replace it is because the testosterone declines quickly after you start taking these pills. And when you stop taking the pills, your testosterone recovers quickly, which is much more empowering to my patients that they would have more control over when their testosterone comes back. Also, I don't like getting, I wouldn't want to, I don't like getting stuck in the abdomen or the butt. It's painful. Sometimes that pain can last for weeks after the injections. So these pills called Orgovix or Regululex are, I think, a bright, hormonal therapy definitely has side effects, but men having more control over it, I think, is a big improvement in the care of men. Also, these pills might have less cardiac side effects. So when you're on hormonal therapy, I don't know if this is like, people don't tell you this, but your diabetes could get worse. Your cholesterol could get worse. You gain weight. It makes your blood pressure go up. So hormonal therapy definitely has adverse side effects for your general overall health. And limiting the time you're on it could be a good thing for some patients, specifically patients who have intermediate risk prostate cancer who only need 6 months of it.
So let me put in a good word for androgen deprivation therapy in this
Okay.
respect. You tell me if it's a BS kind of thought, but we have people who are virtually telling me what to ask. So here's what
Okay.
to ask. It sounds like SBRT works best when you could define the geography of the prostate and deliver what you need and no more, no less. If the prostate is large, there's more opportunity for it to butt up against the rectal wall.
That's true.
So why not make it smaller in advance of beginning the SBRT? And perhaps the way to do that is 3 months or whatever of androgen deprivation therapy to artificially to create a smaller prostate, and then you start figuring out where and when and how much to deliver.
I'll tell you one thing. Your audience is very intelligent, and that's an excellent thought. We already do that for men with unfavorable intermediate risk prostate cancer and high risk prostate cancer. I almost always give 3 months of hormonal therapy before I do the radiation. And that 3 months of hormonal therapy maximally shrinks the prostate by 30%. And it reduces the volume of the prostate so that the rectum, the bladder, and the penis probably get a lower dose of radiation due to that 30% reduction in the target volume. So I would say most of the patients that we're treating in this day and age are intermediate and high risk because we're trying to do mostly active surveillance for the low risk patients. So a lot of the patients in our clinic will actually get hormonal therapy for 3 months prior to the radiation.
Yeah, so that is a thing you're doing.
That is the thing we're
Okay.
doing for men that need the hormonal therapy. I usually do it 3 months before.
Okay. Men with prostatitis tend to present with a larger prostate, and are offered a month or so of Cipro or some other
Yes.
antibacterial. Is that a possible substitute for androgen deprivation therapy? Those 3 months of androgen deprivation therapy, might those be replaced by Cipro?
So Cipro is an antibiotic that's used to treat prostatitis, but it does not shrink your prostate.
Ah, okay.
For men
But
with low risk prostate cancer, with large prostates that are going to undergo SBRT, what I commonly do is I might put them on finasteride or Avodart to drop their prostate size prior to treatment.
yeah, and finasteride can restore your hair if you're lucky as well.
I mean, to me, it's a drug that was probably developed first to restore your hair, but then they noticed the benefit that it also shrinks prostates.
Is that true? Like it was, that's how it was?
It was a hair agent first.
Ah,
Yeah.
okay.
The
Yeah.
the dose of finasteride for hair is lower than the dose to shrink your prostate. So usually for hair, it's 1 milligram a day. If you want to shrink your prostate, it's usually 5 milligrams a day.
Okay. So as we close off this really good discussion about radiation therapy, and I think we're arming people with better conversations for their radiation oncologist. And just as an interlude, very briefly, difference between radiation oncologist and radiologist.
So a radiation oncologist is a therapeutic radiologist. Basically, they use radiation to treat cancer or benign disease. Radiologists interpret films. So, like, let's say you have abdominal pain and you get an x-ray. A radiologist will look at that x-ray and interpret it to figure out what's causing your abdominal pain. Radiation oncologists use radiation to treat cancers. They don't like really, they don't like look at scans to try to predict what the problem is. They actually, there's a known problem like a cancer, and they use the radiation to fight that cancer.
Okay. And just some quick fire things, does radiation hurt?
The good news is radiation, you can't smell it, you can't see it, it doesn't hurt. And actually, I always, every once in a while, I have a patient who gets upset with me because I didn't tell them it wasn't going to hurt. Radiation doesn't hurt. The first day you get treated, you're like, did you guys do anything? Are you doing a placebo effect? Radiation does not hurt.
Okay. Do you need a full bladder to do SBRT?
So the old treatment techniques that were not very accurate, we used to do full bladder. I don't do full bladder anymore because the accuracy of this SBRT is sub-millimeter. So we don't treat a lot of bladder when we're treating.
Okay. And after and before, you could eat, drink, do whatever you feel like doing?
I usually tell people I don't want your rectum moving a lot. When we're treating you, I want your rectum to be empty and not moving. So actually, human beings are closer to worms than you would think. When human beings eat something, their rectums usually move or their bowels usually move. So I usually tell people not to eat anything 4 hours before we irradiate them because I want our irradiation to be as accurate as possible.
But they don't have to do fleet enemas or anything like that.
I usually, when I'm treating people with SBRT, I usually put them on a low fiber diet to make their rectum small, and I'll usually make them do a Fleet's enema before the treatment planning MRI and before each treatment.
Okay. And so an MRI is required prior to
I
figure this
always
out.
do a treatment when it's possible. I always do a treatment planning MRI to let me have a better idea of the patient's specific anatomy, and I use a CT scan for dose calculations.
So the CT scan delivers radiation as well. Is that taken in?
It's a
How
very
do you
low
play that?
dose of radiation. I'm treating someone's cancer. I mean, the radiation that we give during the treatment is a lot higher than any dose of radiation you would get from a CT scan.
Okay. And it just occurs to me, how many CT scans of the modern CT scan era can a human go
Oh,
through without thinking
I
twice?
mean, it's a very low dose. I would say I've never had a patient who couldn't have a CT scan again because they had too many.
Well, would too many be 20 or 5 or what?
The dose is so low that I mean, some people need CT scans on a regular basis to monitor how their health is doing, and I think it's a low dose. It's kind of like going to the dentist. How many dental X-rays can you have?
Well, I mean, I don't want a lot.
There is no limit. I mean, it's the
Uh,
dose is
okay.
so low that it'd be an astronomical number of X-rays from a dental. It's just it's such a low dose. It's by the way, we're in a radiation environment right now. Both
Yeah,
you
yeah,
and I are getting exposed to radiation every day.
yeah, yeah. But for just so let me just push you just a little bit for more for a number. 5 CT scans, don't think twice. 10
Right.
CT scans, don't think twice.
So
When?
some people, when they're giving radiation, they do a CT scan every day to align the prostate and to guide the treatment. That's called a cone beam CT scan that's on some linear accelerators. And you'll do 40, if you're getting treated with conventionally fractionated radiation, they'll do 44 of those scans on you. So I wouldn't be concerned about. Of course, I never do a scan on somebody unless they need it. But if they need it, the dose is really low, and I think the benefits outweigh the risks.
Okay. And SBRT is about 5 doses.
It's
Is
most commonly it's 5. Some people do it in 4. One of the projects that I'm excited about in the future is people are starting to go see whether we can do it in 2 fractions, because
okay.
I'm all about patient convenience. I don't want you sitting in my radiation oncology department when you can be out enjoying time with your friends, traveling in Europe, taking care of any grandkids you have. So I always want to limit the number of fractions to the smallest number that can be done safely and effectively.
Okay. What are the complications that HIV positive people, both the newly diagnosed with HIV and people long term from the 90s and
So the
2000s,
I've actually,
vis-a-vis
not that I'm that
radiation?
old, but
Yeah.
uh, I just think the fact that HIV is basically, I don't want to say it's cured, but people with HIV are living as long as people without HIV. I think it's one of the greatest achievements in medicine, and I think we should all be proud of that. When I used to treat people who were HIV positive that were not on the medications, they had terrible reactions in their skin, and they had terrible reactions in their anal areas and in their rectums. So now, when people are on their medications and their HIV is well controlled and their CD8 counts are normal, they don't have a lot of reactions from radiation. So I don't treat well controlled HIV positive patients any differently than I treat someone who comes off the street who's not HIV positive.
Okay, good. So as we sort of wind this down, and thank you for taking time to speak to us today. What let's talk about your idea of what are the top 5 or 6 or 3 or 4 questions that men who enjoy sex with other men should ask or bring up with their radiation oncologist. Things that are unique and perhaps straight men would never think of or need
Yeah.
to ask.
I mean, I would say that if you're having anal intercourse receptively, I think it's a really good question to ask about, like, are you going to damage my anus? Modern radiation treatments for prostate cancer, the anus gets a very low dose of radiation. And I think the long-term impact of, I don't think you'll have anal stenosis after radiation for prostate cancer. You will not need anal dilators after radiation for prostate cancer. So I think things are a lot better now than they were in the past. If you get radiation, modern radiation for prostate cancer, although you might have less ejaculate, you'll probably have some ejaculate. Um, you'll still have a prostate in place, so it's not like your prostate's going to disappear if you have radiation. It'll be a lot smaller, and it might be less sensitive, but you still will have a prostate.
Any other questions you think apropos?
It's I am very I try to be as open as I can with patients, and there is no bad question. So you should try to find a radiation oncologist who thinks there is no bad question.
Yeah. And the idea of a man being out to you, uh, there's free your office, it's elegant and welcome. What strategy might you offer a gay man or a bisexual man to be out to a doctor and try to imagine somebody that you think may be a bit dicey to be out to?
Yeah, it's funny. I grew up in Queens, New York, and from my experience, that wasn't a back when I was growing up. It wasn't a very gay friendly place. I think Washington D.C. I actually, I assume that my patients could be gay. It wouldn't be surprising to me. It'd actually be surprising to me if I didn't have gay patients in my practice. It's one of the best parts about Washington D.C. is that we're very open minded. I think we have a modern society. One of the things I am upset about is that I think for some reason, um, I don't think Georgetown sees a lot of transgender men. and women. I wonder if that's for several different reasons. First of all, we were or we are a Catholic institution, and I hope that doesn't drive people away from seeing doctors at Georgetown. One of the things I'm also upset about is that public transportation to Georgetown is not easy, specifically for people who are, socially challenged, don't have resources. If I had to vote, I'd vote to have a subway stop right outside the front door at Georgetown, but I guess I don't get to vote. Um, and so I think one thing that we have to do a better job is being more welcoming to transgender patients.
Yeah.
Because I know they're out there, and I'm always surprised that I'm not seeing them.
Yeah. Well, on one of the days of our conference, it's a 3-day conference. It's dedicated just to transgender women,
Right.
and we have at least 2 who are speaking up, as well as a couple of doctors who treat transgender practice. But for today, or whenever anyone is watching this morning, this afternoon, this evening, um, thank you, Dr. Collins, for taking time to explain. And for our audience, it's what Dr. Collins was saying is just the tip of the iceberg. There are, thousands of ways to treat people, because there are thousands of people who have precise needs, and it's up to you to be precise with your doctor and insist that they be precise and open and interested in you. 90% of this game is to find doctors that are interested in who you are. So,
By the way, I have the best job in the world, man. Being a prostate doctor in Washington, D.C. is like the best job in the world. I meet the coolest people. I mean, I meet people from all walks of life, from all around the world. I meet people who are, homeless on the street. I meet people who are, running the government. Every day is a new adventure for me. I never know what's going to walk in my front door, but it's always interesting and exciting.
right. And do you do a digital rectal exam on every famous person that walks in?
I probably enjoy that more than well, put it this way. Um, Digital rectal exams are part of the staging for prostate cancer. Okay. So generally, good urologists usually do that as part of the original staging. All the urologists that I work with usually do a digital rectal exam as part of the initial staging. If it's not documented in your chart that it was performed by another experienced provider, then I'm examining your prostate because you can't make a decision for a patient without that information.
Yeah, yeah.
Does it
And I
bother you when
suppose
they do it? Did you rectal exam on you?
no, it's I don't find it pleasant, but I mean it's not at all. I find dentistry a billion times worse. Uh, I've had prostatitis. I found the cystoscopy doable, but I wish you could find a way to numb my anal
Oh,
sphincter, I
interesting.
guess.
So you
Yeah,
think the problem with numbing your anal canal when you do a digital rectal exam is
not anal,
numbing
bladder neck,
bladder
sorry.
neck, sorry, bladder
Yeah,
neck,
yeah, yeah,
right?
yeah. Good you caught me on that. Another reminder, I'm a social worker, and my my anatomy experience is based on a coloring book I did years ago. You know, the little, the anatomy coloring thing. No, the general idea of we have to do what we need to do, and pain is will be over in a minute, you know but the information we gather may be life-saving and useful in ways that we can't imagine or predict. You're collecting clues about your patients,
Yeah.
and every test, every opportunity to touch them, painful or not. And most of these things are not painful. They're just something you wouldn't volunteer to do, but it's over so quickly you forget about it 3 seconds
You know what
later.
I do to make it easier? So
But
to make it easier, I always have a very light personality, and I'm always telling jokes because if you're laughing, your anal sphincter is very relaxed. So I always try to be a very positive, upbeat, funny kind of guy because that relaxes your anal sphincter before I examine you. The other thing is that I always tell people, well, first of all, when you're examining someone's prostate, you have to insert your finger slowly. You can't jab into the to the anal canal. So it's very important that you're bent over at a 45-degree angle and that you go in slowly and you tell a joke before you do the exam. And usually it goes really well.
That's interesting. I would have thought that laughter sort of constricts things.
It relaxes. Being in a positive environment where you feel
Mm,
comfortable
sure.
relaxes your anal sphincter.
Very good. Okay, so everyone should carry a joke book or
I use the same jokes all the
tape.
time, by the way. I
Yeah.
always tell the partners when they're leaving the room, if you hear any screaming, I'm okay. That's my standard joke. The partners laugh. The patient usually laughs, and usually I get a very good exam with very minimal pain.
Excellent. Dr. Collins, thank you for the care you provide your patients, and thank you for being part of our conference. And welcome to Mailcare's faculty.
Please invite me back anytime you want.
Okay, thanks.